hydration status, the third thing about respiratory status. Because the patient will die from one of abnormality of one of these three things. Appearance, whether the patient is awake, active, playful, happy, or he is lethargic, irritable. Usually children, they cry. Whenever they see a stranger, they cry, especially infants. But if they cry and their mother hold them and became quiet, that's normal child.
Yes.
But if they cry and continue crying, this, regardless of whatever you do for them, that's maybe irritable child. Okay? So toxic appearance, irritable, lethargic, comatose, that's all abnormal. If he's happy, playful, smiling, these all good things. So you have to mention that whenever you assist a patient, whether you are a nurse or a doctor, you have to mention how is the appearance of the patient. Remember, there is a triangle. So number one is appearance. From appearance, you can tell whether this is going to need a resus or this patient is going to wait outside or regular bed. Just from the appearance, without touching even the patient. Second thing, we look for signs of respiratory distress. There are 5 signs of respiratory distress. One of them is what? First, without touching the patient, you are from distance now.
Nasal flaring.
Wheezing.
Nasal flaring.
Okay, nasal flaring, خلينا نبدأ بالنص. Nasal flaring. Rapid breathing. Retraction. Okay, قبل that, before you come close to the patient from outside, from distance. Nasal flaring, wheezing, تسمع صوت, wheezing, stridor. So stridor, wheezing, flare, nasal flaring, cyanosis. Okay. Rapid breathing, you see him breathing very fast. Then you will come close to the patient, and maybe you see here there is what? Suprasteroid tagging or suprasteroid notch movement. And then after that, you have to expose the patient. Check for recessions or drawing of the chest. So any of these abnormality is called respiratory distress. Also add grunting. You know grunting?
Yes.
If you hear a child or adult having that, means he's trying to open his alveoli, similar to the CPAP. So that's natural CPAP cause. So grunting, together with the other we mentioned, all signs of respiratory distress. If the patient is having any of them, he needs to be inside, not outside. This is without even touching the patient. Before you check the saturation, remember that saturation will drop when the patient is dying almost. If you lose the battle, the saturation will start dropping. Many patients, especially asthmatic, they have normal saturation with all the respiratory distress findings. Maybe not cyanosis, but they have tracheal tagging, respiratory rate high, stridor, wheezing, intercostal recessions, but saturation is normal. So don't rely only on saturation.
Yes.
Look at the patient. You are not treating the monitor, treating what? The patient. So we said appearance, respiratory distress, and third one is hydration status. Okay? So hydration status, you look for what? Yeah, sunken eyes, dry lips, weight loss, weak pulse,
Skin turgor.
drop symptoms. Okay? But don't forget to check the legs. Okay? If you feel the patient having cold extremities, that's a sign of dehydration, severe dehydration. Remember, blood pressure can be normal in children until the last moment before they die. So don't rely on blood pressure, on hypotension for children. Diagnosis of shock in children because of severe dehydration, you will not discover it by blood pressure. You will discover it by features of severe dehydration, like cold extremities, a weak pulse, sunken eyes, maybe he's drowsy, of course. If he's in shock, he will not be smiling, he will be drowsy, or maybe comatose, or irritable. So if the patient is having any features of severe dehydration, that's also a sign of worry. We need to patient inside. Most important to check also capillary flow. Okay, for 2 seconds, if 2 seconds or more, that means the patient is having severe dehydration, moderate to severe dehydration, meaning he should be inside. Okay, so remember this triangle, and need to use it for every child you see. Personally, and whenever I see a child, before I came here, I assess these 3 important factors, and sometimes I document that in my notes. You can use also these 3 signs for adults, because these have the similar findings in adults and pediatrics. Now, if you have a patient with asthma, a child come to you, he is 5 years old, coming with shortness of breath, he is known to have asthmatic, he is not having any medication at home, he depends on the health center for nebulization. How will you approach this patient? In triage, what you will do for him? Nurses first, tell me what you will do for him in triage. Quiet, that's okay. So you assess blood pressure, saturation. Remember, yeah, if you come, patients or the mother is distressed, baby is distressed, fathers, and they usually come as cluster, like group of people. So try to control the place. Tell them only the necessary people to be in the triage room. And check if the appearance of the child is drowsy, forget about vitals, forget about anything else, take the patient inside. If he's asthmatic, short of breath, and he's drowsy, that's a sign this patient should be inside, maybe in recess, not to waste time outside. If he is active, trying to breathe, but he's happy, there's time. You can continue the full assessment in the triage. It's very important to document the appearance of the patient when you write to the triage. We'll come to that maybe in the triage workshop, not now. But if the patient is very sick, take him inside. If he is not appears sick, you can, the usual process. Now, he appears short of breath, he's audible wheeze. So how will you treat him? Just a comment, what you will do for a patient with asthma exacerbation.
Take his kit off his
Let's start with that oxygen, because patient might not be able to communicate at the moment because he's having shortness of breath. Or we can ask the history and then ask the patient like whether he can continue talking with us. Then we can ask the history about like whether he has been taking any medication prior to this attack or not.
He is non-asthmatic. Let's assume he is non-asthmatic. No.
Asthmatic. Then we can start with we can see the saturation and then start with the oxygen.
Okay, so if his saturation is normal, he's asthmatic, right? But his saturation is normal, you can give him nebulization by nebulizer machine without oxygen. So we have a soft nebulizer without oxygen, that's fine because saturation is good. So that nebulizer draws the air from outside, 21% oxygen, draws air and gives the patient the ultrasonic salbutamol and ipratropyl bromide. If he is hypoxic, give him oxygen. You go on more hypoxia without oxygen.
So we'll start with the salbutamol epitropine or we'll just start with salbutamol nebulization?
Good question. Now we decided about he needs nebulization. Now the question whether, the question was whether to give him with oxygen or the nebulizer. If he's hypoxic, oxygen. If he's not hypoxic, nebulizer. Okay? Now the question, what is next? What will you give him? Salbutamol alone, ipratropine alone, or combination?
We will follow the stepwise pattern for the asthma in the children and asthma in the adults. So we need to move on from short acting, then to long acting, then we can move to internal hydrocortisones, then we can, that pattern we need to follow.
Okay.
Yeah.
We'll come to that in a moment.
Yeah.
So any patient, I'm talking about non-asthmatic. I'm talking about not yet
Not asthmatic.
non-asthmatic. So what you'll do, give them 3 back-to-back of combination of salbutamol and atropine. So the dose for pediatric is 2.5 salbutamol, 125 atropine. Mix them together and get them back-to-back. The first one, immediately second one, immediately third one. Forget about IV access. Give them nebulization first. And importance, back-to-back, because we know this patient's having asthma attack. That's their treatment. And if they are still very wheezy and they are not improving, give them now the fourth nebulization without atropine, just salbutamol. So atropine only for the first 3 doses. Subsequent doses will give them only salbutamol. If they are still short of breath, give them another 4, 5 until they improve. Usually after the 5th nebulization, if they're not improving, you start searching for other causes. I will ask for chest X-ray. I will check for ABG, looking for acidosis. Maybe he is metabolic acidosis. He's not having asthma attack. He's non-asthmatic, but now he came with different disease. That's why we need to check reflow. Sometimes they come with DKA. And DKA, they come not with diagnosis here, they will come with symptoms. And symptoms usually rapid breathing, nausea, abdominal pain. Cosmal breathing. Okay, so don't be trapped, this is asthma, it's only asthma. Especially if they are not improving with your treatment, look for alternative diagnosis.
Other differential diagnosis.
Other differential diagnosis.
Yes.
Usually metabolic acidosis.
Metabolic acidosis.
So treatment for asthma is back-to-back nebulization. First 3 doses is a mix of salbutamol and atropine. After that, you will give them only salbutamol. Don't forget steroids. Steroids, you have to give it as early as possible. Maybe after the first nebulization. Let them breathe some salbutamol. Then after the first one, give them immediately the steroids. So what type of steroids you would use for these cases? IV, hydrocortisone, usually that's what we give them, right? What's the duration? Dexamethasone, IV or oral? IV, okay. So hydrocortisone is commonly used, but the duration is only 8 hours. That's why after they leave us, they come next morning with the recurrence of their symptoms. So that's why we prefer to give them prednisolone or dexamethasone. The IV form of prednisone is called methylprednisolone, which we don't have it. That's fine, not an issue. We have.
We don't have also maybe a vial.
Yeah, we have requested dexamethasone. Yeah, so dexamethasone. Fair enough, that's okay. Now, if the patient is able to swallow, guys, if the patient is able to swallow, he does not need an IV. Remember, he is having trouble breathing, now you are giving him another trouble. If he is able to swallow, he does not need IV. Especially if the patient is not in rhesus, especially if the patient is not severe asthma. You can give them oral steroids. And it's almost equal efficiency. There are studies that show there is no difference between IV methylprednisolone and oral prednisolone. So hydrocortisone is out because of duration. Not bad, but duration only 8 hours. If you give it, you have to give another steroid after 8 hours. Or repeat hydrocortisone every 8 hours. So I prefer not to keep hydrocortisone as first-line steroid. I prefer to use either prednisolone oral, dexamethasone oral, or methylprednisolone IV. So there is no difference between oral and IV in terms of prednisolone. So please use prednisolone. It's 1 milligram per kg for children. Adult, give them 50 milligram once a day. Okay? So if you decided later to discharge this patient, he does not need more than 4 or 5 days. The first dose is given here, second dose will be tomorrow, for 4 more doses.
50 milligram once per day.
For adults.
Once per day.
once a day. You can divide it 25, 25. But you don't need after that to taper the dose. You stop.
Just stop.
5 days and stop. There is no worry about rebound or whatever complications.
The dose of prednisolone for pediatric is 1 milligram per kg, but there is an upper limit, I think 40.
40.
Yeah,
Yeah.
maximum 40, not more.
For adult, maximum 50.
Adult.
تمام? So if the adult weight, for example, 70, you don't give them 70. Give them just 50 only. That's the maximum. Right? So there's no difference between IV and oral. We said oral lasts longer also. So you gave them now salbutamol 5 times with the first 3 with atropine, and they are not improving. And you are sure they have asthma attack. What else we can offer this patient?
Magnesium sulfate.
I can't hear you.
Magnesium sulfate.
Magnesium sulfate. So magnesium sulfate. How magnesium sulfate is useful?
It stabilizes the
Muscle relaxer.
Muscle relaxant, stabilizes the walls of the muscle. Okay, so bronchodilation. So one thing when you give magnesium sulfate, you need to watch out for one important thing.
Heart and
Heart rate
That is very
and blood pressure, because it can cause hypotension. So be careful. If the patient is having hypotension, don't give them magnesium sulfate. Right? So it's better if you think the patient is going in the severe track of course of the disease, better to start it early. Right? You give the first 3 nebulization, you give steroids, and you feel the patient is not improving. Start magnesium sulfate. You don't wait until the last moment before he dies, then you give him magnesium sulfate. So start it early. What is the dose for adult?
2 grams.
2 grams over
about 10 minutes. Like
20 minutes.
20 minutes. Right?
Pediatric, check the dose. You should have a reference
50
for
50 microgram.
50 microgram per
kg.
kg. That's why we need to wait every child who comes to emergency. عشان medication doses. Okay? So let's assume this patient appears like almost he's going to die now in front of you. He's asthmatic.
Intubation.
Wow, okay. If you want to kill the patient faster, asthmatic, intubate him. He will die quicker. I'm not saying don't intubate asthmatic. I'm saying try to avoid intubation.
Try to avoid.
To avoid. By what? By aggressive, remember the word, aggressive nebulization. Early steroids, early magnesium sulfate. Try to avoid intubating an asthmatic patient because the pressure in the lungs will be very high to the degree they will have a cardiac arrest. So because positive pressure, because of ventilation, it will causes alveolar rupture, and also it can cause decreased venous return to the heart, and they develop cardiac arrest. So be very aggressive in nebulization, steroids, and early magnesium sulfate, but you have one important tool with you.
Anesthesia. Vaccine.
Aminophylline.
Aminophylline.
Aminophylline is used to be, but now it's out. If you have aminophylline with you, throw it away.
Before it was given, it used to be given IV also, infusions,
Right.
but it was outdated now.
Because of the efficiency of the nebulization,
Yes.
it became out of flavor. They are using it in ICU in very limited cases, number of patients.
Intravenous salbutamol.
We don't have adrenaline. Okay. So if you think the patient is deteriorating very fast, and even that oxygen or that nebulization is not reaching the lungs, you want to give that medicine, which is in the salbutamol, you want to give it IV, as you said, which we don't have. Alternatively, you can give them epinephrine. How do you give epinephrine? It's not reaching because close
Subcutaneous.
IM. It's not IV. Forget about IV epinephrine. Nobody is using IV epinephrine except for cardiac arrest. So we'll use it IM. Not sub-Q, it's IM in the deltoid. Either adult or children. We can still use it in the deltoid muscle. The dose for children, you have to check it. I think it's 0.25 0.01 milligram per kg.
Okay.
And the one you are using for IM injection is not the IV dose. It's IV injection, IM injection, sorry. It's 1 in 1,000 concentration. I'm talking about adrenaline or epinephrine. It's 1 in 1,000 concentration. The one that we give it through the IV is 1 in 10,000, which is diluted, much more diluted. So we're giving here 1 in 1,000. We'll give for adult 0.5 ml for adults, IM. For pediatric, we need to check the dose. It's 0.01 milligram per kg. I think to the maximum, I think of 0.5 or something like this. Yeah, it should not exceed the adult dose anyway. Okay, and you'll use epinephrine if you feel the patient is going faster, deteriorating faster than your treatment. By that way, the medicine will reach to the blood and will cause bronchodilation from inside. By giving nebulization to cause bronchodilation from outside. Okay. So in summary, asthma is very common. Treatment for adult is same for pediatrics, no difference. Same. The difference only the dose. Pediatric nebulization is 2.5 milligram, nothing less than that. Don't follow whatever it said in the books. Give per kg. Nebulization for children is minimum dose is 2.5 milligram for salbutamol and 125 microgram for the atropine. Right? That's, and you can repeat for 3 times back to back. Then after that, salbutamol 2.5 as needed. For adult, the minimum dose for salbutamol is 5 milligram. Minimum dose for atropine is 250 microgram. And mix them together always for the first 3 doses. The other medicine is steroids, which is very important, has to be given as early as possible. There's no difference between oral and IV in terms of efficiency. The oral is preferred because it lasts longer. I prefer if we have dexamethasone because it lasts for not only longer, it lasts for 2 days, which is good in our setting. And complaints will be much more important than this. The third medicine or fourth medicine, which was magnesium sulfate. And the dose you know, in adults, 2 grams, in pediatric, we have to check, it's 50 micrograms per kg. You treated this patient, he improved, you decided to send him home. So remember to give him, make sure that he has inhalers with him. ما ينفع يروح البيت and without proper inhalers. So inhalers, tell him to take maybe TID for the next 2 days together with the steroid you give prescription for prednisone.
And if not improved, then?
If not improved, this is what happened yesterday. We had a patient who kept overnight yesterday. It was the first patient to go overnight. And today, the first patient we referred to SQH for bronchiolitis, this different one. Yesterday, what we did, the patient, after he received the initial treatment, he did not improve, gave him more nebulization, slightly improved, but not to the degree that he is dischargeable. Ideally, he should be admitted. If you can't discharge, you can't keep forever in emergency. You have to admit, but we don't have admission. So what we did, we kept the patient in emergency. So initially was back-to-back nebulization. He improved. We said, okay, we'll do it now every 30 minutes, salbutamol, for 3 times. We noticed that he is improved slightly. Now we make it instead of every 30 minutes, we make it every 1 hour. Repeat it for 3 times. Then assess. If you notice he's improving now, we make it every 3 hours, nebulization, until he is better to the degree that you can discharge him. During the acute attack, if you want to know if the patient is improving or not, what method you can use to know if the patient is improving with your treatment or not in the acute attack? Patient cannot talk.
Clinical assessment and vitals.
Okay, saturation from the beginning is normal and now it's still normal.
Assess the chest.
Squeezing.
Decrease by the kilometer.
Spirometer is the best. يعني بس we cannot do it. Spirometer, peak flow meter is the best. Like in patients acute attack, you cannot stop the treatment to ask him to do it. They will not allow you to. So ask a patient from a distance. Child, you look at the appearance.
He looks comfortable.
He looks comfortable and
Comfortable.
It maybe he is deteriorating and looks comfortable. If he is drowsy, then that's maybe an early sign that he is retaining CO2 and now you are losing the battle. But if he's adult and adult patient, ask him, is it like this or like this? Most of them, they say, we are good. If they didn't respond to you or they're saying that's this, you know that you are almost losing the battle. Then in that case, you may go for intubation. But don't put intubation first. Try to avoid intubation by all means. Another way, talk to the patient. When you initially assist him in the triage, he was only saying maybe 3 words together. And you can say only, my name, like this. Now, if he can continue one sentence without interruption, then that tells you that he is improving. Just by talking to the patient, you will know whether he's improving or not. In children, we rely on the appearance and the respiratory rate. If the respiratory rate was 60 and now it is 40 and he's awake, then that's a reassuring thing. But if his respiratory rate is down and he is drowsy, then maybe he is going in the wrong direction. So that's why the triangle is important. You align the appearance with breathing with the hydration. I think it's stop here. If you have any questions, let me know.